Lady, can you see and hear me?
I can, Ms Blackpool, thank you.
Thank you. This morning's first witness is Dr. Pauline Nolan. May she be sworn, please.
Could you start with this? Repeat after me. I do solemnly, sincerely and truly, declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth. Thank you.
Thank you. Thank you. Can you begin by giving us your full name, please?
My name's Dr. Pauline Jane Nolan.
Thank you. And Dr. Nolan, you should have in front of you a copy of the witness statement, which is signed by yourself on behalf of Inclusion Scotland, Nuala Toman on behalf of Disability Action Northern Ireland, and Cameron Malik on behalf of Disability Rights UK.
Yes.
For our reference, it is INQ 000 655 852. Can you confirm, please, Dr. Nolan, that this witness statement has been provided on behalf of all three organisations that make up the Disabled People's Organisations?
Yes.
And that the facts stated within it are true to the best of your knowledge and belief?
Yes.
Thank you very much. I'd like to begin by giving a brief overview of each of the organisations. You together have substantial reach across the United Kingdom, do you not?
We do.
Yes. For example, Disability Rights UK has a substantial following on social media with over 72,000 ex-followers, and it had over 1 million visitors to its website during the pandemic. You tell us that Inclusion Scotland represents disabled people across Scotland with a wide network of partner organisations, and that Disabled Action Northern Ireland is the largest Northern Ireland-wide disabled persons-led organisation and membership organisation. Is that right?
That's correct.
And together, you provide a variety of different support services to disabled people across the UK, including advocacy, employment support services, digital connectivity, transport, community integration, information and advice, mental health and well-being services, and you also raise awareness, you campaign with government departments on key issues impacting disabled people in society, and the overall goal is to improve legislation, policies and practices. Is that right?
Yes.
Thank you. You tell us at paragraph 11 in your statement that disabled people have a wide range of impairments and or long-term conditions, that you include autistic people, people with learning disabilities, those with sensory, cognitive, mobility and energy limiting impairments, and also people with mental distress.
Yes.
Some of you face multiple discrimination, you tell us, on the basis of disability, race, age, being LGBTQ+, and or other personal characteristics. Is that right?
That's right.
We heard from Professors Marmot and Bamborough in the inquiry last week that all of the social determinants of health apply more to disabled people. And does that accord with your understanding?
Disabled people face various health inequalities, absolutely.
Thank you. Turning then to mortality rates, please. The inquiry heard last week from Professors... Yes.
Should I have reports coming up on the screen, because I don't?
No,
Okay.
I was hoping, Dr Nolan, that you had agreed with me that you've got a copy of your report before you.
Okay.
That I am about to put up a table, in fact, from Professor Shakespeare and Watson's report, which shows the... Thank you very much. Which shows us the age standardised mortality rates for deaths involving COVID-19. This table shows the rates in relation to men. Mm-hmm. And Professors Watson and Shakespeare pointed out to us last week that the difference between more disabled men at the top and non-disabled men at the bottom in terms of mortality rates within wave 2 of the pandemic was threefold. So in other words, more disabled men were 3 times more likely to die in wave 2 of the pandemic than non-disabled men. And for the sake of completeness, please can we display table 2, which shows similar figures, but this time for mortality in women. And we can see that those rates are very similar.
Yeah, I think we broadly, we quote slightly different statistics, but during the pandemic, we've quoted that disabled people accounted for approximately 6 out of 10 deaths, and that comes from the Office of National Statistics. It was 7 in 10 in Wales.
Yes.
And it increased for different groups of disabled people, including different equality backgrounds.
Thank you.
And including different impairments as well.
And you also go on to tell us that for some disabled people, thank you, we can take that down now. For some disabled people, the mortality rates were even higher than those that you've just provided us with. For example, there was a Public Health England report that estimated that people with learning disabilities were 6 times more likely to die compared to the general population. Is that right?
That's right, and the death rate for 18 to 34-year-old people with learning disabilities was 30 times higher.
30 times, 30.
Which is a really shocking rate, and that was in the same age group compared with the same age group without any disability.
Thank you. Would you agree that a significant reason for the mortality statistics that you've outlined is the fact that many disabled people also had underlying health conditions which increased their risk of severe outcomes from COVID-19? That is, that they were clinically vulnerable to the virus?
Yes, so I do agree with that. Many disabled people did have underlying health conditions making them clinically vulnerable, but also many disabled people didn't necessarily have underlying health inequalities or conditions making them clinically vulnerable, and that would include this group of people with learning disabilities.
Yes.
Whose sort of health inequalities in the first place were worse than for the general population for a range of reasons, and who were more likely to be living in group housing, have social care support and not have information in accessible formats. And so there are other reasons why people were more likely to die of the pandemic apart from clinical vulnerability. But of course, as Shakespeare and Watson Professors Shakespeare and Watson have laid out, that does play its part.
Yes.
And yeah.
Thank you. They also have described, haven't they, and Professors Shakespeare and Watson, what's termed a triple jeopardy due to the pandemic. So disabled people were at greater risk, first, of negative outcomes from the disease itself, second, reduced access to routine healthcare and rehabilitation, and thirdly, the deleterious social impacts of efforts to mitigate the pandemic. And so one has to take into account that they have told the inquiry those 3 different types of effect. Do you agree with that?
Absolutely. Inclusion Scotland, right at the start when we were reporting on our survey, we described that as rights at risk, but it's the same thing. It's across the board, both the disease itself, the actions taken, and the loss of access to healthcare, which was really
deleterious.
Yes.
Yeah. Thank you. Moving on to mental health and well-being, please. You tell us at paragraph 15 in your report that in April 2020, Disability Rights UK highlighted a study by the Office of National Statistics, which found that nearly 2/3 of disabled adults stated that COVID-19 related concerns were affecting their well-being. And in a study published a year later, in April of 2021, again by the Office of National Statistics, it showed that the disproportionate impact of the pandemic on disabled people's mental health and well-being had persisted.
Yeah, the data in our report shows that a range of, the statistics show how disabled people felt like a burden. We felt stressed and anxious. Our mental health deteriorated. We were lonely and isolated, and we had no one necessarily to talk to about any of it. It was one of the starkest findings of our own survey, Inclusion Scotland survey, undertaken in April 2020. We know that suicide rates were already higher for disabled people than the general population, and they went up as disabled people faced increased levels of stress, anxiety and loneliness. And we actually, in fact, had 15 respondents. We hadn't explicitly asked about mental health in our survey,
yes,
but 15 told us that they were feeling suicidal at the time of their response.
Thank you. The position, it would seem, was very similar for clinically vulnerable people. And I'd like to just display, please, part of the witness statement of Miss Lara Wong, who is coming to give evidence later this morning. Thank you very much. This, for the record, is at page 60 of her witness statement, where she talks of the psychological and emotional impact of COVID. Isolation was widely understood by members as necessary for survival. This is in relation to clinically vulnerable people, but also deeply traumatic and psychologically costly. From CVS' recent survey, 95.2% of respondents described negative mental or emotional impacts linked to shielding or cautious living, including stress, depression, anxiety, loneliness, suicidal thoughts, burnout, and other trauma. These effects were often felt not only by the person shielding, but by other household members, including children, partners and carers. Shielding, especially when unsupported, resulted in significant psychological fallout. And there were two examples given. Firstly, of Emily, 54, who said, "Myself, my husband and my 2 adult sons all shielded to protect my CEV husband. As a result of this, we lost friends. I lost my job, affecting my confidence and self-worth. My eldest son's mental health has been severely affected, and he is now on a medication and awaiting counselling." And of Vivian, aged 62, "In short, it has ruined our lives. One person had to give up working as a GP. Both suffered emotionally and socially and continue to do so. Winters are unbearable. We are locked away. We cannot go into any dining or entertainment venues, nor to friends and families' houses. We spend Christmas alone. It's not living, it's existing." And finally, on this topic, the mental health toll was closely linked with deteriorations in physical well-being due to a lack of safe access to healthcare, including cancelled appointments and fear of infection in unmasked clinical settings, reduced mobility and exercise, especially for those who did not feel safe anymore, and the exacerbation of existing chronic conditions due to prolonged isolation or stress. So, serious toll on mental health and also deteriorations in physical well-being. Are those two effects very redolent of what your members were telling you?
Yeah, absolutely. People were left alone, given limited guidance. People were never sure. A lot of disabled people who were potentially also clinically vulnerable or at risk were not necessarily put on the shielding list, but were shielding and self-isolating without support, without information, and it really had a really disastrous effect on mental health for many people, individuals and families.
Thank you. We can take that down, please. To your knowledge, during the pandemic, were there mechanisms in place to identify early signs of escalating mental distress or suicide risk among disabled people?
No, not to my knowledge.
What, in your opinion, could or should have existed?
So, had authorities had data and information about disabled people and their circumstances, they might have been able to offer advice via GPs and health settings and mental health support services. They might have been able to offer online or, face-to-face support was all but gone, but telephone or online support could have been offered. Of course, that wasn't accessible for everyone. But just checking in and, public campaigns as well would have been helpful. This idea of never seeing people once they brought in the, measures where people could see people, it was still dangerous for a lot of people to do that. So that had a worsened effect. And of course, we know that it's still dangerous for people now who aren't getting their needs met in public places and health settings as well.
Thank you. Turning to look at some of the factors that increased detrimental mental health impacts for disabled people, you have identified within your report 6 areas. Firstly, the financial stresses and poverty. You tell us at paragraph 18 that the intersection between disability and poverty is well documented, and that across the past 2 decades, poverty rates have been, on average, 11% higher for families with a disabled member compared to non-disabled families.
Yeah, we estimate that 50% of households, so actually it wasn't estimate, it was just fact, before the pandemic, 50% of households with a disabled person in them were under the poverty line, living in poverty.
You tell us at paragraph 19 that it's well known that the experience of debt is strongly associated with poorer mental health outcomes. What did that mean for people on a personal level?
On a personal level, it was it made people really distressed and worried for the future, unable to afford food, unable to, you know, so there was an example of one person, I'll find the quote, who was absolutely terrified, couldn't afford to put on the heating.
Yes, I think that's at paragraph 19.
Yeah, thanks.
Heating is off,
the
night
heating's
time.
Off, night. Yeah,
sorry, go on.
Yeah, I'll find it. Sorry, bear with me. Page. Yeah.
Shall I read it to you, Dr.
Sure, yeah.
Heating is off, night time I use candles. I can honestly say I have never been so unhappy.
Yeah.
And none of this is helping my mental health and severe PTSD.
That's right, yeah.
And in terms of the second identifiable factor increasing mental health deterioration, you tell us that one wholly avoidable cause amongst disabled people during the pandemic was access to key public health guidance and advice.
Yeah.
So is it your experience and that of your members that not only was the advice late in coming, but it was also unclear when it did come?
Yeah. It was various types of advice, including shielding, as I've already mentioned,
yes,
but also clinical protection, and even the daily announcements from the Prime Minister, there was no BSL interpreter,
yes,
so deaf BSL users were excluded. Scotland did introduce one for the First Minister after pressure from ourselves, Inclusion Scotland. But then letters were sent to disabled people in inappropriate formats, and guidance was actually inconsistent. And there was no co-design, despite the fact that we, Inclusion Scotland, and the Scottish Government were facilitating co-design on social care support. That just dropped off during March and April 2020, when the government went into crisis mode and failed to co-design, and it all increased in people's anxiety.
Well, that's what I want to concentrate on. What was the impact of all of that? You say an increase in anxiety?
Increase of anxiety, not knowing what's going to happen, fear of the pandemic, fear if you are, there was that clinical frailty scale that came out, that disabled people were put at level 5 and level 7. Between level 5 and level 7, were told that they wouldn't get treatment, and then they pulled back from that.
But it
was too late. Yeah, that change in guidance, it was too late for many disabled people who'd heard that. Felt like a burden, felt like they were scared of going to the doctors, going to hospital, not being ventilated. It was a real fear.
So even though the position improved with the clinical frailty score,
the message had got out there.
Yeah. All right. The third point that you raise is digital exclusion. And you say at paragraph 25 that linked to the anxiety caused by the lack of information was whether or not it was in an accessible format for many disabled people. Going online meant that they were removed from from having an ability to access that material.
Yeah, so we already knew in 2019 the data showed that disabled people were more likely to be offline than non-disabled people.
Yes.
With 21% saying they had no access to the assistive technology that they would have required. And in 2020, 42% had low or very low digital engagement due to, for example, low digital literacy, lack of internet coverage, including in remote and rural areas, insufficient funds to cover access requirements. And at the same time, many services went digital by default, and disabled people weren't being considered, the barriers weren't being considered, even though these issues were well known. And that was what was really frustrating about it. Initiatives were set up to provide devices, but they failed to account for digital barriers. And in late 2020, I'll leave it there.
Right. I was just going to say that you go on at paragraph 27 to tell us that there were some efforts made, which I think you've just accepted.
Yeah.
But it wasn't enough. The digital divide was not bridged, is how it's described.
And there was funding available for third sector equality groups to do projects to connect people, but we were unable to access because we weren't providing specific services. Inclusion Scotland weren't. But later in 2020, we did actually receive funding. All the DPOs across the UK received funding from the National Emergency Trust, the DPOs that are part of this inquiry, I mean.
Yes.
A National Emergencies Trust. And it meant that we were able to put funding out to DPOs across the UK. And in Scotland, we provided 9 DPOs with funding, and some of those used it to connect disabled people isolating who faced the greatest barriers. So we made sure it was about independent living and removing barriers.
Thank you. Other issues that you raise are reduction in social care support, barriers in access to mental health care and support, and finally you mention intersectional trends in mental health. As we heard yesterday from Professor Beccares, LGBTQ plus communities are at a higher risk of suicidal thoughts, suicide attempts and self-harm compared to people who don't identify as such. And we know that disabled people, in terms of suicide rates, as you set out at paragraph 42, include those who have faced discrimination for their sexuality and gender.
That's right. Yeah, there were disabled. There was an LGBT Foundation survey that surveyed LGBTQ plus disabled people, LGBTQ plus people in general, and found that disabled individuals were more likely to want access to mental health support and were less likely to feel safe where they were staying compared to other non-disabled respondents.
Thank you. I'd like to turn now to ask you about access to key services and support, and in particular, the reduction in access to healthcare services. You tell us that at paragraph 52, in Scotland, a Glasgow Disability Alliance survey reported that the pandemic had seen crucial healthcare treatment cancelled, with NHS Scotland reportedly cancelling 73% of planned treatment in the month of April 2020, and that this meant that disabled people lost access to essential healthcare and treatments, including physiotherapy, pain clinics, neuro appointments, and other vital services. And was that position reflected across the UK?
It absolutely was. The Glasgow Disability Alliance are one of the biggest members of Inclusion Scotland, and so they did their own research survey of their thousands of members. But reduction in access to healthcare disproportionately impacted disabled people. There were over over twice as likely to report that access to healthcare had been affected and more likely to report that medical treatment had been disrupted during the pandemic than non-disabled people.
Thank you. Reduction in social care support, including for those in residential settings. At paragraph 54, you say, for recipients of social care report, and particularly those in residential settings, you heard accounts of disabled people experiencing reduced access to healthcare services, such as cancelled visits to GPs, community nurses, mental health services, and podiatrists. And you were also aware of reports of instances where care home residents were not transferred to acute settings and people nearing the end of their lives didn't receive adequate palliative care.
That's right.
And again, was that reflected across the UK?
It was, yeah.
Thank you. For many disabled people across the UK, the greatest impact of the COVID pandemic was on how they accessed vital support through social care support. So firstly, I'd like to ask you about the impact of the pandemic on the reduction in social care support services. And we'll look at 5 examples that you give in your report.
Yeah. Multiple reports showed that a large number of supported people lost some or all of their social care support. Our own April 2020 survey showed that 30% of respondents said their usual support was either stopped completely or reduced, sometimes overnight and without any warning.
Yes.
And this deeply impacted our rights to independent living. So, for example, our NIB Cymru survey showed 66% of blind or partially sighted respondents felt less independent than they did before lockdown. And it was also a postcode lottery due to responsibility lying with local authorities or, as in Scotland, integrated health and social care authorities. So it depended where you lived, but for many it was just overnight stopped, and people were really anxious about not getting social care support recovered after the pandemic because they were seen to manage.
Thank you. Is it right that in some cases care workers who had previously worked with adult disabled people were reassigned to care for older people, leaving disabled adults without any care and support?
We weren't told what happened to social care support workers, but many were, yeah, I think so.
Thank you. Domiciliary care and recipients of that. We have heard from Professor Shakespeare and Watson that there was a lack of understanding regarding domiciliary care and that this was a problem across the UK. For example, not appreciating that many disabled people relied on domiciliary care, and a member of Disability Wales, I think, you told us at paragraph 75, who usually received 3 care and support visits of 45 minutes each per week, which enabled her to bathe and to do other things which she couldn't manage herself, was cut off without any consultation or warning.
Yeah, and as we said, causing her considerable distress and loss of personal dignity. And this was not isolated at all. It was across the board. It included people with personal assistance, and we've heard from my former colleague, Dr. Jim Elder-Woodward, who was saying that because his PAs had to self-isolate, but there was no alternative source of social care support, so he was just left high and dry, literally, like sitting upstairs without any support, without any washing or... Yeah, and he had a mental health crisis due to that. But yeah, by May 2021, it also caused increased deaths, so possibly more, I think, in proportional terms than those who died in care homes. About 28,000 that we know of, recipients of domiciliary care, had died across England and Scotland by May 2021. And again, it was the postcode pandemic, the postcode lottery pandemic, where areas like Slough and Haringey saw 677.8% and 431.3% increases respectively. And it's upsetting because these risks were known and predictable.
Dr. Nolan, increases in what?
In deaths.
In deaths.
In mortalities, people in social care support.
Yeah.
Some had to rely on family and friends, moved to live with family in houses that weren't accessible. I'm just painting a picture here.
Yes, of course.
So that they continued to get care. Some were unable to get up, having to sleep in wheelchairs without any personal care support at all. Some had support cut down, that example of someone losing time to properly wash.
Yes.
But there was no contingency at all, no planning with disabled people who received support. It was just...
And no warning.
And no warning.
Can I ask you about impact for people with learning disabilities, please? You deal with that at paragraph 91 of your statement, and you refer to the report entitled Living Through the Pandemic, the Impact of COVID-19 on People with Learning Disabilities in Wales, which was based on a survey of two groups, people with learning disabilities who were Group 1 and family carers and paid staff who answered questions for those who were unable to answer for themselves, and that was Group 2. What did that survey tell you?
It told us that, is this the one that said, 26% said they didn't receive any support, whilst 32% said they were getting less. And that carers of people with profound learning disabilities, 9% said the person that they cared for was getting no formal support, 48% said they'd got the support reduced, and other services were closed. So, for example, day care centres and respite centres, which disrupted long-standing routines and social connections for those disabled people. So isolation was a key concern there as well. Deteriorating mental well-being, which had its impact on carers as well as the cared for person.
And members of families who live with disabled people.
Yeah.
And although that was a Welsh survey,
that was across the board,
that was reflected across the UK.
And guidance was inappropriate. It was ARC Northern Ireland that was saying there was no guidance, and if there was, it was inappropriate, conflicting and inaccessible.
Thank you. The next topic is impact of rules and guidance, and we have touched upon this already, Dr. Nolan. You've told us that there was a lack of translation and messages that were being issued by the government, both verbally and in written form, were not often translated into many languages, and the British Sign Language organisation had to step in and help in that regard. You've also told us about digital exclusion, and you've explained to us the impact of that upon those who were unable to access services digitally. Mm-hmm. I want to just ask you about the phrase vulnerable and clinically vulnerable, and ask you whether you agree that clinically vulnerable as a phrase functioned as a descriptive public health term to identify people at increased risk of severe outcomes from COVID-19 due to their own health conditions, age, or the fact that they might be undergoing certain medical treatments.
Yes, it did and it didn't. So it did for groups that had certain conditions, as Watson and Shakespeare have laid out.
Yes.
But it didn't, for example, for those groups of people that I've talked about who had underlying health inequalities and people that saw themselves as clinically vulnerable but didn't get the shielding letter, were self-isolating without any of the advice or support that came with that. So it's a bit more nuanced, I think, than it was used. I think it was used inconsistently, and it wasn't always applied to the right groups.
Yes.
Necessarily.
Thank you. Moving to deal with the impact on specific groups of disabled people. You tell us at paragraph 130 that the proportion of disabled people who had to endure shielding and lockdown restrictions in unsuitable housing was an unacceptable hardship caused by a failure to address pre-pandemic issues. The impact, you tell us, of that was that during periods of shielding and lockdown, disabled people were forced to spend extended periods of time in unsuitable conditions, leading many to report feeling trapped in parts of their own homes. And you refer to a YouGov poll that was commissioned by the Habinteg Housing Association in 2020, which found that of disabled people who described their activities as limited a lot, 21% said that the inaccessibility of their home undermined their well-being during lockdown. 35% said they were not able to carry out all daily tasks in their home with full independence. And almost a quarter of all disabled respondents said that they did not have a home which met their access needs.
Yeah.
So disabled people, you tell us, were also at heightened risk of homelessness.
Yeah, and the lack of accessible housing was an issue again that we'd already been campaigning on, but there was delays at the time to things like occupational therapy assessments for aids and adaptations, and that we've noted a 47-year wait for wheelchair accessible homes. DRUK have given an example of Banana Faye, who had damage to her adapted bathroom before the pandemic, and then the lift to a toilet broke early on in the pandemic.
Yes.
And due to the delays, it took 2 years for the flooring to replace, and she was feeling really unsafe. And then another example, a young woman who was a member of Inclusion Scotland,
Yes.
Reported, and GDA, I think, Glasgow Disability Alliance, reported having to move to her parents' house due to living alone, but her PAs could no longer access the house because the house was inaccessible. She was living in their living room. She had no access to the bathroom. So she had no personal care support. We've got 44% at risk of homelessness.
So you're describing issues that were present before the pandemic that were exacerbated by changes during the pandemic to care and to support.
Yeah.
And you were just going on, I think, to talk about homelessness and the fact that going into the pandemic, 44.1% of people who identified as homeless were disabled. Crisis described in autumn 2020 how there had been a continued new flow of people experiencing homelessness since the start of the pandemic. And although they commended the Everyone In programme for providing support and reduced infection rates, they noted that the structural barriers that existed prior to the pandemic, including a limited housing supply and a welfare system that didn't address the underlying causes of homelessness, only increased during the pandemic. So more people were becoming homeless.
Yeah.
Turning, please, to deal with those disabled people who experience domestic abuse. Now, the inquiry has heard evidence about this recently, in fact, as recently as yesterday. And you cover this topic at paragraph 139 in your statement, where you say that disabled women are 3 times more likely to be victims of domestic abuse compared to their non-disabled peers, and that the disabled people's organisations were therefore particularly concerned to hear reports that the rates of domestic abuse increased during the pandemic. You go on at paragraph 140 to say that the lack of care workers coming into people's homes forced disabled women to be more dependent on partners and family members while also being more isolated, with reduced outside scrutiny, which resulted in instances of psychological and physical abuse. And you go on to describe as particularly alarming the increased domestic abuse rates during the pandemic, and that often abusive partners were not leaving the home due to lockdown policies, and therefore the opportunities for survivors to report abuse was limited.
Yeah, and for example, for specific groups of disabled people, people with learning disabilities who might have relied on a carer who was abusive and who had no access to advocacy either, to be able, or people who had no access to comms support to report abuse. It was a real concern, and different groups of disabled people, particularly women, also LGBTQ disabled people, BAME disabled people, all potentially affected, and it doesn't matter who you are, where you're from, you can be affected by domestic abuse, but because of disability and the barriers disabled people face, it's exacerbated, the risk is exacerbated, and the impacts can be as well.
Thank you. Finally, on this topic, those in mental health wards, prisons and places of detention. At paragraph 143, you tell us that in June 2020, the Equality and Human Rights Commission stated that the criminal justice system was failing disabled citizens and needed reform to ensure fairness for all, and that followed the publication of the EHRC's report, Inclusive Justice, a System Designed for All, in April 2020. They had noted that there was an overrepresentation of people with learning disabilities and mental health issues within the system that the government had failed to document. And it went on to describe how accused individuals who were not routinely provided with the adjustments they needed to participate in the justice process further suffered when the process became digitalised. Because of the reasons that you've already set out. To help address these issues, you tell us that the EHRC called on governments to adopt their recommendations, which included addressing gaps in the collection and monitoring of disability data and support for the duty to make reasonable adjustments. And in light of those criticisms, the criminal justice system didn't allow disabled people, in your opinion, to fully participate in matters that they needed to. Is that right?
Yeah. Infection rates also went right up in prisons, also in places of detention where disabled people were more likely to be. I think we've got now new data suggesting around half of prison inmates are disabled people. That's in Scotland, at least, with a really recent report. And people were stuck in isolation for long periods and didn't have their adjustments met or mental health support given. DRUK, our colleagues at DRUK actually produced updated guidance on regulatory changes needed within the justice system throughout the pandemic. So we were working hard to address it.
So there are two issues there, I think, aren't there? There's those who are present in places of detention and prisons, and the difficulties that disabled people in those positions experienced during the pandemic, and there are issues relating to access to the justice system.
Yeah.
But both of which, I think, suffer, in your opinion, from a lack of suitable data. Is the collection of data for disabled people something that, in your opinion, should be improved?
It's one of our recommendations, the collection of disaggregated data. And of course, we've made an emphasis on disabled people having intersectional barriers because of being from different equality backgrounds, potentially. And so that data needs to be collected as well, and no matter how small the data might be, it would address, meeting different disabled people's needs, which currently aren't met. There was also issues in mental health wards as well. I'm sure you're going on to that though, but in detention there was infection prevention and control measures meant that people were just isolated, and so the mental health would have been much worse.
Thank you. Is there anything else you would like to tell us about those in detention during the pandemic, disabled people?
There was a UCL study that found that 38% of older adults in psychiatric wards in London were infected at the height of the pandemic.
Thank you. Going back, if I may, to an improvement that's needed in data collection, what has been the impact of insufficient data being available on disabled people and their plight during the pandemic?
There's decisions being made that don't take account of needs, don't take account of access requirements, including access to information and guidance, didn't take into account, for example, the people employing PAs and disabled people in social care, domiciliary care, who weren't getting the protections that people in hospitals and care homes were getting, the masks and coverings and so on. Across a range of different protections, these weren't applied accessibly to disabled people because the data wasn't there. So
yes.
Yeah.
So, and that's why it's so important that it's collected.
Absolutely,
and considered. Paragraph 153, you talk about the need for consultation. And you say this: in order to understand the needs of disabled people from their perspective, a surface-level approximation is not good enough. Improved systems of consultation and participation are not just about providing feedback on services and flagging issues, but also in sharing success stories of what has worked well and delivered public value. As healthcare increasingly moves to digital services and becomes more reliant on automated decision-making, it is all the more important that those advances are not hindered by inaccessibility and failures of inclusion. Finally, throughout the process, there was a lack of structured support and engagement for the use of the third sector. Organisations, including DPO, were expected to contribute to pandemic efforts while maintaining existing commitments to funders, beneficiaries and the state. Such organisations are often grassroots bodies and, while faced with limited resources, are well positioned within communities to disseminate messages, engage cohorts and then collate and provide feedback.
Yes, yeah.
So there are two questions that I have about that, please, if I may. Mm-hmm. So the first is the need that you identify for there to be consultation about disabled people's needs, but in particular with third sector organisations such as your own. Mm-hmm. And the second issue, I think, and please tell me if I have this right, is that those organisations, such as your own, as you have already made reference to, stood up during the pandemic and pivoted the funding that they had in order to aim it at the provision that was most in need. So is funding going forwards an important issue as well?
It's always an important issue for DPO. We do have good recognition in Scotland of the role of DPOs, not necessarily in other parts of the country. But we did, at the start of the pandemic, we were in fact funded to do co-design and co-production, which is the best way of consulting and informing disabled people, involving disabled people. And we were funded to co-produce reform of social care support, adult social care support in Scotland. And the funding wasn't removed, but the people in Scottish Government that were working with us were all moved into COVID crisis response and didn't bring us with them. And they knew about concept of co-production and co-design. And yet that wasn't taken forward at the time.
What was the impact of that?
Well, I've mentioned earlier confusion and anxiety, but also just lack of knowledge of people's needs and preferences, their access requirements, and how they're impacted.
So that is something which needs to be considered going forward.
Absolutely, yeah. Key recommendation, yeah.
Thank you very much. Dr. Nolan, those are all the questions that I have for you. My lady, I don't think that there are any additional Rule 10 core participant questions. I noticed the time, and I don't know whether my lady wants to rise now or to move on to the next witness, who I'm told is ready to start.
I'm in your hands, Miss Blackwell, and the witness's hands. I don't know if you'd rather break now, and then it's up to you. I'm being given a message, I think, from outside. Yes, I think we'll continue, please, until the natural breaking time. Thank you, Dr. Nolan.
Thank you. Thank you very much.
Dr. Nolan, thank you very much indeed. Some of the stories you've told us were very distressing, and I do understand and appreciate the work that you and your colleagues do for people who suffered so much. So thank you very much for all that you and your colleagues did and for your assistance with the inquiry.
Thank you for allowing us to give this evidence. It's so important that you hear it. Thank you.
Thank you. My lady, in fact, there's a change of plan. May we have our break now, please? And we'll come back after 15 minutes if my lady agrees.
Just keeping me on my toes, Miss Blackwell.
Yes.
Very well. I shall return at, well, shall we say 10 past 11?
Yes. Thank you very much.
Thank you.
Thank you.
Got you.
My lady, welcome back. Can you hear and see me?
And thank you.
Good. The next witness is Lara Wong. May she be sworn, please?
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Thank you so much.
Is your full name Lara Wong?
Yes.
Miss Wong, you should have in front of you a copy of your witness statement. It bears our reference INQ 000657970. Please, can you confirm that that is the witness statement that you have provided to Module 10 on behalf of clinically vulnerable families?
It is.
And can you confirm that any facts stated within the statement are true to the best of your knowledge and belief?
They are.
Welcome back to the inquiry. I understand that you have previously given evidence in modules 4 and 8.
Thank you, yes, and I appreciate being invited back. It's very, very good of you.
Thank you. So the inquiry is already aware of your organisation, but I will introduce it briefly, if I may. Clinically Vulnerable Families is a grassroots organisation founded in August of 2020. You are the Chief Executive Officer of the organisation, which represents those who are clinically vulnerable, those who had been identified as clinically extremely vulnerable, and including people who are severely immunosuppressed and those in their households across the United Kingdom. Conscious not to repeat work already undertaken by the inquiry, I remind us that Module 3 has looked in detail at shielding and the clinically vulnerable and clinically extremely vulnerable population and the impact on their health and access to health care. It has examined the impact of the shielding programme on people's mental health and well-being and considered the problems encountered in identifying people who were clinically extremely vulnerable. And it has looked at some of the practical challenges faced by people who were shielding, including accessing healthcare and the effectiveness of the shielding programme as a whole. This module has heard from Professors Herrick, Majid, Shakespeare and Watson on issues of definition. And so the inquiry has heard that there was an overlap between the two descriptors, that the boundary was not clear, that there was fluidity from both categories, and that definitions changed over time. Clinically vulnerable and clinically extremely vulnerable were labels that came into being during the course of the pandemic. And is it right, Ms Wong, that you hold the view that those who were identified as falling into one category or another were not consulted before those categories were defined and that they should have been consulted?
I wouldn't say that. It's not about consulting those groups. When we're talking about people who are clinically vulnerable or clinically extremely vulnerable, which was a term which, as you say, was used at the time.
Yes.
It was based on their true intrinsic risk that they faced due to the health conditions that they had.
Yes.
And so consulting them wouldn't have changed that risk.
No, but do you say in your statement that they weren't consulted, and that had there been a better understanding of the effects of what they were told to do because they were formulated into one category or another, then that there would have been a better understanding within the government of the restrictive lifestyles that would therefore have progressed?
So, I mean, I think part of it is about the lexicon that we're using here. So it's telling people that they are really vulnerable. And so, yes, I know many groups have objected to the choice of terminology, and to be honest, we don't object to that. We do feel that people may not have understood their risks fully. They didn't understand what that terminology meant and how it applied to them, and also how that affected had changes to their lives. And
so that relates to the messaging, doesn't it? Rather than the delineation of clinically vulnerable or clinically extremely vulnerable categories.
Yes.
Right, okay. There was, of course, at the time that these definitions began to be used, a lack of data because they were created during the course of the pandemic. Is it your view that there is data now available that could be used to identify those who are most clinically vulnerable going into what might be a future pathogenic pandemic?
Absolutely. So, I mean, I think we didn't know, it was a novel virus. We didn't know precisely to what extent different groups of clinically vulnerable people would be affected.
Yes.
We did probably, I would say, know, based on the flu categories, who would be likely to face disadvantage due to their health risks. I say disadvantage intrinsic disadvantage because their health condition, their biological susceptibility, their immune systems put them in that situation where they were going to face higher risks. So those things kind of didn't change, and so we would expect would have resulted in poor health outcomes. And I'm pretty sure if you'd have spoken to any medic, they would have been able to identify the high-risk groups that they knew those conditions would have put them in. And rapidly we could see, once people were turning up in healthcare, there were large numbers of diabetics, for example. There was a third of the deaths were diabetics. We could see that many of them were older. We could see lots of risk factors. And we gathered data over time to get very specific details on them. And obviously, where a group was a smaller group, it was much harder to get that information on them. So we wouldn't necessarily know quite to the extent to which they were at risk, but we would know that they were a higher risk group.
Yes, understood. Thank you. I want to turn to ask you about the impact on mental health and well-being, please, which you begin at paragraph 20 in the report. There are three main areas which you identify. Firstly, the impact on clinically vulnerable people, including survey findings. And you tell us at paragraph 20 that extended shielding, either formal or informal, repeated disruption to healthcare access and prolonged exclusion from everyday activities meant that risk management became a constant feature of daily life. Now, was that for clinically vulnerable or clinically extremely vulnerable people, as they were then designated, or both categories?
It was both, because both of them faced increased risks. So clinically extremely vulnerable was devised by the government to offer the shielding programme, which related to giving food parcels and other sort of social-based care that they were kept within that sort of loop. Whereas clinically vulnerable people were not identified directly, but they still knew that they had those health risks. They knew that they qualified for a flu vaccine, for example.
Yes.
They knew that they were at risk, and so they still had to manage the same risks.
Thank you. And you go on to say that the knowledge that exposure to airborne infections may cause severe illness or death was not hypothetical for those categories of people. The removal of mitigations in healthcare and public spaces, you say, forced people to choose between protecting their physical health and participating in what you describe as may have been essential activities.
Yes, so I mean, I think this is, for us, it's kind of about how your physical health risks, so those intrinsic risks, interrelate with your external environment.
Yes.
So if you are of a high clinical risk, if you are to catch the virus, then your risk of worse outcomes are significantly higher. If you're a healthy person and you catch the virus, your risk of severe outcomes were not particularly high. And so for those people, it was a real problem that they had to manage those risks. And so those environmental risks that they faced did change from environment to environment. So if they lived a quite a reclusive life alone, then their risks might be, if you shielded in that environment, you might be relatively safe, versus somebody who, for example, was a key worker on those front lines, exposed to people not with appropriate PPE. So there were huge differences. And so I think one of the things that the inquiry hasn't really drawn out yet is the difference between people with those intrinsic risks and those environmental extrinsic risk factors and how they interrelate, because just having a high extrinsic risk factor does not mean that you're necessarily going to result with, and so where those domains cross,
Yes.
that the highest risk exists.
Yes, and so, as you say, somebody who was clinically extremely vulnerable but lived a very isolated life would have had a different pandemic experience to somebody who was clinically extremely vulnerable and also had been working as a key worker.
Absolutely. So, like, for example, if you were extremely vulnerable, maybe you were a transplant patient, but you were an astronaut and you were on the ISS at the time, your risk of infection was zero. You were not going to die of COVID. But then if you return to living and you happen to then take up a key worker role, then yes, then your exposure risk then rises. And so your risks obviously shift with that.
Thank you. At paragraph 22, you explained that your organisation gathered insight from its members through a survey called Impact on Society, and we've already made reference to that, and I think we'll look at that soon. The survey ran in the summer of 2025, so recently, and received 125 responses from people in clinically vulnerable households across the UK, which captured experiences over the course of the pandemic. And it combined structured questions on specific impacts with also open text accounts that provide what you describe as qualitative detail. And we will look at some of those throughout the course of your evidence. The survey findings, in fact, we have already looked at, but I'm going to put them up again because they are part of your report. And we can see that the responses showed that impacts were multi-layered, often combining social, emotional and practical challenges. Participants described both the direct strain of living with increased health risks and the secondary effects of prolonged exclusion from safe public spaces, healthcare and social contact. And the key themes emerging from the data included the following. One, social isolation was reported as a major factor for most respondents, associated with shielding, ongoing risk from airborne infections, and the withdrawal of mitigations, for example, masking in public and healthcare settings, leaving many finding it harder to return to their former lives. Two, a large proportion described their concerns linked to increased infection risks, particularly in healthcare environments, workplaces, and high population density public spaces without ventilation or masking. 3, many experienced depression and a sense of hopelessness when mitigations were lifted without protections for high-risk individuals. 4, grief and trauma were compounded by circumstances such as being unable to visit dying relatives, restricted funerals, or lack of post-bereavement support due to shielding. And 5, reports of loneliness were particularly acute in households not only where the clinically vulnerable and clinically extremely vulnerable individual lived alone, but also where they were the only vulnerable member, creating divisions within families about acceptable risk and behaviours. And that final point is something which we touched upon in Dr. Nolan's evidence earlier this morning, that it wasn't just the individual themselves, but the effect that the provisions had upon their family members.
It was, and I think, and I know we'll come on to sort of the government messaging, but I think it was really unhelpful. People often felt really pressured and stigmatised by the fact that they faced these high risks. And in fact, I was talking to one of our members yesterday who recounted a story that's very common actually among our group, where they found that they were talking to their friends about their situation, trying to explain it to them. And the response that they had back was that they should hurry up and die so that they could get their lives back. And so they were being kind of blamed, and they found that they lost friends and family where these divisions were kind of forced and these fault lines fell. And yeah, so focusing on that group in that way made it incredibly hard, and they had to try and manage their own risks, often alone.
Thank you. Just pausing to reflect upon the example that you give at paragraph 30 in your statement, which describes the account of Jayden, who was referred to a clinical psychologist after his Macmillan counselling sessions ended, and whose experience suggested a lack of understanding of his clinical vulnerability, including being encouraged to undertake activities that were not safe. What impact did receiving advice that did not reflect somebody's clinical vulnerability have on their mental well-being and confidence in professionals?
It was incredibly hard. So there was this conflict, again, that sort of grew up around it. And so where a physical health risk was being addressed as a mental health issue, it was a real problem because people didn't understand. People genuinely thought that there was a mental health problem. It's not that it didn't lead to potentially mental health problems where they were facing these real risks. Nobody was understanding them. They weren't being supported even by the mental health professionals that we would hope should understand these risks. So it was incredibly hard for these individuals to manage that situation, and unless that individual had been moved on to the correct professional who could understand how those risks interrelated, and actually then shifted the focus onto the psychological impacts rather than trying to address a physical health risk and trying to reintegrate them into society where actually it was unsafe for them to do so.
So are you also describing a concern about lack of training of professionals?
Lack of training of professionals has been a huge issue, certainly. And I think, and this links to something that hasn't been raised in the inquiry, I don't think, but pandemic trauma is how we would view it. Certainly health professionals, that they were exposed to these incredibly difficult situations and decisions. And even seeing a mask can be quite triggering for those people. But pandemic trauma has affected how everyone has kind of behaved going forward, and it has had a knock-on to this group. And yeah, we talk about moral injury when we talk about healthcare professionals, but there was also the injury on the other side as well, where people have been affected negatively, and also how that then affects them and how they view the value of their own lives.
Yes. And that's something which the inquiry has heard about before. Thank you. Factors impacting on mental health and wellbeing then, as well as the ones that you have identified. Within your report, you identify the closure and subsequent opening of cultural, leisure and recreational facilities, which you say had a profound and lasting impact on clinically vulnerable people. Let's display, please, a case study that comes from your statement. It's page 15, thank you very much. And it's the case study of an actress who is clinically extremely vulnerable due to cancer. She said this: by the autumn of 2020, when theatres were tentatively reopening and I was starting to do remote auditions, I was diagnosed with cancer and started 18 months of chemo and immunotherapy. I was severely immunocompromised and I had to shield. So, ironically, if I thought my life felt dispensable before, with those appalling government adverts suggesting ballet dancers simply abandon their hard-won careers to retrain in cyber, then it was nothing compared to how I felt my life looked now. Not only had I been shut out of my workplaces since March, but the door to every aspect of public life now appeared firmly locked. My day-to-day became much rockier to navigate. Suddenly, the narrative became, if you're scared, just stay at home then. That was the same in theatre. I have actor friends who were told not to test so that they wouldn't know if they had COVID. Some theatre producers were basically saying, if you don't know, then you can come to work, but you don't have to feel guilty about it. That wasn't the kind of environment I could safely return to, despite the fact that my hair was growing back and I was starting to feel okay, despite still being on treatment. But the big issue was that I was still immunocompromised, but no one can see that, can they? People expect those who are going through cancer to look emaciated and sick, but immunocompromised doesn't look poorly. It's an invisible health problem. And was that, thank you, we can take that down, please. Was that a confused case study, something which is common in the stories that you've heard from your members?
It was incredibly common, and I think the fact that clinically vulnerable people weren't truly being recognised as a group, their risks became invisible, even though we knew very clearly at the start of the pandemic, all of the news reports were saying, this person lost their life, sadly, but they had underlying health conditions. It repeatedly came up, and for this group, they felt the pressure of every single loss and that sadness. But, you know, the lack of... The fact that they weren't offered support increased their risk. The fact that people didn't want to address it and would rather not tell people that they were sick increased their risk. When I'm talking about increasing their risk, their exposure risk,
yes,
not their intrinsic risk.
Yes.
And the fact that we didn't give them the information and knowledge that they needed about higher grade masks that we knew about. We knew that a high-grade mask can filter the air up to 99% or more for an FFP3 or 95% for an FFP2. They weren't told that they could manage their risks in a better way. We weren't working on improving ventilation in a sustained way. And other protections and awareness within society that these people existed. They became invisible, and it was uncomfortable. People didn't want to know about it because they wanted to move on with their own lives, partly, again, due to their own sort of pandemic trauma.
Thank you. Let's look at two other examples of impact, please, at page 17 of your report. Thank you. First, Aisha. I felt a great deal of grief at missing out on events that were part of my identity, such as gigs and comic cons. When places opened, families and friends assumed I'd attend. The lack of information to the public about CV people meant so many went back to pre-pandemic lifestyles. I feel guilty that my child has missed out on wonderful experiences like visiting museums. And you go on to say that the failure to provide even minimal accommodations, such as support for those who mask or outdoor events, was, in your view, exclusionary. For clinically vulnerable people, it's about the right to participate in public and cultural life on equal terms. Reopening, particularly following Freedom Day and living with COVID, without protections, effectively denied many their rightful safe access to society and continues to do so. Now, I'd like to look, please, at the Impact on Society survey, which took place and the report is dated, I think, October. Yes, we can see at the bottom, a pre-release, October 2025. This is the document to which reference has already been made. And I'd like to go, please, to page 16 and to have a look at society, culture and hospitality. Thank you. So it starts with a quote from Robin. I was unable to attend my daughter's wedding abroad. I felt very lonely. No hugging or physical contact with my close family was difficult, especially when my first grandchild was born. And then this, for many clinically vulnerable people, reopening was not experienced as freedom. The removal of protections such as masking, ventilation, occupancy limits made everyday activities more unsafe. Hospitality, retail and tourism were repeatedly identified as especially inaccessible since eating and drinking required unmasking. The government's Eat Out to Help Out scheme amplified the divide by promoting indoor dining without safeguards at a time when no vaccines or treatments were widely available. This effectively excluded vulnerable households and reinforcing their feelings of abandonment or incentivising risk-taking behaviour. Venues rarely provided information about ventilation or crowding, leaving people unable to assess the risk. So just pausing there, the impact of not having information available to people to make choices meant that people were taking a risk in attending such venues.
Yeah, so they understood their intrinsic risk,
yes,
but they also understood how that exposure, extrinsic risk, would make things more inaccessible to them. And so where those measures were withdrawn over time and kind of gradually, every single step down made them feel even further excluded from society, and places became inaccessible to them, particularly high-risk environments. And that's where we saw people choosing to delay or cancel medical care because the exposure risk in healthcare is much higher. And so those even essential reasons to leave your home,
yes,
became inaccessible.
Yes. And then finally, just on this page, an additional impact was that many expressed frustration that online or hybrid access to cultural events, which had been valuable, was quickly withdrawn once protective measures were lifted. The sudden loss of hybrid access was experienced as another layer of exclusion, removing opportunities for connection that had briefly opened up. Were similar frustrations and experiences encountered with the closure and subsequent reopening of places of worship?
Yes, it very much was, and actually some very sad cases of people who felt so excluded by their religious community that they felt that actually they would give up on their faith completely, because for many people, I think for many faiths, they talk about vulnerable more broadly, and I think in a pandemic, you know, it is the clinically vulnerable that are going to be the most at risk from the outcomes of the virus itself. I'm not talking about the wider outcomes, and so, you know, I think where they thought that their faith had particular values, and they felt that then that clashed with their lived experience, and so yeah, those environments became inaccessible for them, and even things like funerals where they lost loved ones to the virus itself, they felt they couldn't attend even when people could attend.
Thank you. Well, let's look at some examples of that, which we can see at page 19 of your Impact of Society survey. We felt like our faith-based values, caring for the vulnerable, were completely abandoned. It hurt more coming from people we trusted. And we can see among respondents who had engaged in religious life, participation, as you've described, Ms. Wong, was widely affected. 54.6% said significantly affected, 35.9% somewhat, and 9.3% said they were unaffected. Early online services helped, but later withdrawal of mitigations and online access left many feeling abandoned or excluded from communities and key rituals. Hybrid and outdoor services early in the pandemic were widely valued. Later, the removal of live streaming and mitigations created difficult choices around funerals, weddings and communal worship. Several respondents described tensions within congregations about masking and ventilation that affected their sense of belonging. And clear expectations set by faith leaders, together with practical precautions, made a noticeable difference to inclusion. Steps sometimes taken included opening windows and doors, services without singing, providing a masked area, or remote options. And then we see the experience of Morgan. I hadn't realised until it stopped how much my weekly services meant to me in terms of my mental health. The community and social aspect of going to church is very important to me, and when this stopped, it was very hard. Unfortunately, 2 significant events happened during the time frame that greatly challenged my Christian faith, and without the weekly face-to-face support, I felt very isolated. All this has made me turn my back on organised religion, and I am no longer a practising Christian. So quite a severe reaction and impact for that particular person.
Exactly. I mean, it was incredibly harmful. These people felt that
Thank you.
their religion should provide them some kind of refuge and sort of safe space. And actually, in some of these instances, it led to greater isolation when these things were removed. It's not to say, just to kind of give a positive angle, it's not to say that we didn't learn through this. And actually, I've heard many stories sort of since of weddings and funerals and things abroad, where people can attend internationally, yes. And people are aware of this now. This is a new way to kind of connect people. But it doesn't always happen, and I think that's the thing. It like I said, it became kind of a barrier to this group to be able to engage.
Thank you. The restrictions on carers, family visits or access to advocates, as you describe it, during lockdown. Paragraph 53, you tell us that this had severe, wide-ranging impacts on mental health and sometimes on the dignity of individuals who were unable to care for themselves without that level of care. And, of course, that chimes very much with what Dr. Nolan told us this morning about the removal of social care packages.
Yeah, it did, and I think it had a massive impact on people's sort of mental well-being when they faced these particular restrictions. It affected their autonomy, their safety, and they had to, households. And when I talk about clinically vulnerable families, we talk about the whole household. They were all impacted by this, and so they weren't being provided with adequate support. And for us also, that included things like PPE, if the PPE provided was non-existent or was inappropriate, or where people felt that they interpreted government guidance that pointed to personal responsibility as a personal choice, and they felt that they shouldn't need to wear a mask. They didn't understand that the risk that those people faced in their own homes, and that perhaps it's something that they should be able to request, and also obviously issues like respite and the fact that those families who were taking caring responsibilities 24/7 with no let up,
yes.
There was no kind of opportunity for them to safely transfer the care for a short period of time, and I don't know how you would deal with that, but it certainly was something that was a real issue for people.
Yeah, thank you. Moving to look at the impact of the pandemic on clinically vulnerable and clinically extremely vulnerable people compared to the rest of the population. There are 3 topics to cover here. First of all, the extended periods of shielding that were imposed. What was the impact of that on those who abided by the shielding rules?
So, I mean, shielding had positive sides to it, whereby people were receiving support and extra assistance. But also it had the negative side of people feeling sort of excluded in many senses from their workplace, from their colleagues, from their friends, from their families. And so they had to kind of manage their own risks independently. And so I think it kind of fell on the individual and how they understood what their risks really were, how they reduced their risks. It wasn't always clear for them. And so there was kind of unequal mental health harm on that group, and kind of ongoing. As I'm not sure you're aware, we paused shielding at certain times.
Yes.
Shielding was paused not because those individuals, their intrinsic risk had changed, but because the pressures on the NHS had reduced.
Yes.
And so...
But so far as the impact of shielding on those individuals were concerned, and you...
So the shielding was at certain times, sorry,
Yes,
just to
yes,
explain, yeah, so,
yes.
so they weren't shielded when they were still at really high risk sometimes.
Yeah, right.
And yes, sorry.
And that led it to its own impact, I think is what you're saying.
Yes, because they felt like that they'd been ignored and they didn't understand how the withdrawal of shielding changed their real risks.
Yes.
And so people who may have felt that their risk was completely changed may have gone out and gone to eat out to help out, and then had increased their exposure risk at a time when cases were rising. Or people who then completely withdrew and felt that they had no support and they didn't understand why they'd been dropped in that way.
Yeah. You talk also in your statement about various socio-economic groups of clinically vulnerable people. And you say at paragraph 77 that you only have minimal data on this topic, but it suggests in itself that further research is needed to investigate such intersectional experiences.
Yes, I mean, that's our broader message to the inquiry, is that because we're not recognised as a group, because this data wasn't collected, we are really limited in what we can say, but we do know for a fact that these experiences were very real and wide-ranging, and so without that data, it's really problematic to then for the government or decision makers to respond to. So we do need some really firm evidence to be gathered, and we can do that retrospectively.
Thank you. Paragraphs 81 to 98 of your report address what many clinically vulnerable family members reported as their experiences in terms of dialysis, cancer, immunosuppressed patients, those who were older, obesity, diabetes, and those with learning disabilities.
Yep.
I mention those because I'm not going to dwell upon those in your live evidence this morning, but my lady, you have that evidence in the report, and that will all be taken into account in this module. So I want to move on, please, to look at the impact on access to services and support. And you deal with 7 examples here. The first is accessing healthcare and healthcare behaviours. And you say at paragraph 189 that your survey revealed widespread barriers to safely accessing healthcare and support during the pandemic. Is that right?
Yeah.
Yeah. You go on to say at paragraph 100 that as awareness of airborne transmission increased among clinically vulnerable people and those in their households, their assessment of risk in shared clinical settings changed, with the subsequent withdrawal of measures such as universal masking and attention to ventilation and isolation of potentially infectious patients. Many responders reported to you that even though clinical services were technically open, they were often inaccessible because of the environments in which they were being provided.
And yes, very much so. And this is where you're increasing the harms to a group who were already facing health issues, health disadvantage. You're increasing it because they then can no longer access the additional care and support that they need. And in particular areas, where you have to demask, for example, dentistry, where someone's up very close to you, it was and remains a concern for people that they can't manage those risks independently, which is why we would be asking for sort of broader measures and clean air standards and things like that to hopefully make those places more accessible because they're essential care.
Yes, thank you. You also talk about the use or lack of use of face masks in healthcare settings, of local improvements to air quality, of the exclusion from services due to risk or shielding of people, and accessing benefits and or financial support. So were all of these factors that you identify within your statement affecting the quality of life that clinically vulnerable and clinically extremely vulnerable people were managing during the pandemic?
Yes, hugely. And I mean, I think you mentioned sort of universal credit.
Yes.
And so I think for that group, for example, I mean, there is a recognition, it's interesting, there is a recognition in the application for universal credit of health conditions as different to disability as a disadvantage and considerations.
Yes.
But it's not protected in any way. But that group, it's recognised that they will have these issues and these challenges. It is problematic for them because they're disadvantaged as they're going through this process, and they're disadvantaged by their risks. And they were invited for face-to-face appointments that they had to attend in order to receive the money that they needed to live. And so it's not just clinically vulnerable in their households as well,
Yes.
but yes. And so it posed particular challenges because they didn't have a choice.
Well, we're going to look at the experience of Phil. Again, this comes from your study and the impact report.
Okay.
And this relates to accessing universal credit. And he says, I was a key worker on a 0 hours contract when I rapidly became very aware that I was also at high risk from COVID. Every day that I worked before I locked myself down felt like living with a ticking time bomb. Planning each move to avoid risks, the risk of working became too high. My employer was aware of my health risks, as I was explicit early on and asked not to be put anywhere where I was covering sick staff. However, they repeatedly and knowingly put me into hazardous situations. I found out through others that I had been used to replace a staff member pulled out only minutes before because they had symptoms. In the end, I made the difficult decision to leave my job a week before the first lockdown because it simply wasn't possible to continue in-person work without risking my health, as I had been surrounded by symptomatic people and was struggling with increasing stress daily, despite doing everything I could to mitigate my risks by opening windows and doors, cleaning hands and surfaces, and eating alone in my car. Initially, I was ineligible for furlough or any other financial support. I had a family and children, but I felt completely on my own. My employer refused to offer me furlough because, as a key worker, there was work still available, and in their view, it was my choice not to take it. Without an income, I had to apply for universal credit, which was a demeaning experience. By the time I had applied, there was a huge backlog. I ended up at the back of a very long queue, and it took months to get a payment. When it finally started, they made errors and overpayments, followed by deductions. Nothing was stable. Later, the job centre began demanding in-person appointments, even though COVID cases were rising again. I begged them to continue telephone meetings, but my work coach told me that although they understood my situation, they had to follow the guidance. I felt completely trapped. I was again expected to put myself at risk just to keep receiving a really low and basic form of financial support. In the end, I had to cancel my ASA in November. I can't remember if it was 2020 or 2021, because I couldn't cope with facing unnecessary health risk and the significant stress of being told to return to face-to-face work in the middle of a wave. The process had already taken a huge toll on me and my family. Choosing to step away from the only financial support I could get added even more pressure, but it felt like the only way to protect my health. We have not recovered financially from that time. The support my family needed just wasn't there. We are now living with financial insecurity and owe money to our extended family who had to help us out. Our future feels unstable, and I haven't made the savings I need to retire one day. All of this happened not because I chose to not work, but because there was no safe option available to someone like me. And although Phil's story sadly contains lots of the issues that you have just highlighted, were there many other people whose lives were touched by only some of what Phil there describes?
Yeah, I mean, yes, very much so. And it's really key that the inquiry sort of understands how those multiple domains of vulnerabilities that beyond clinical vulnerability can overlay to cause these issues. And where Phil mentioned following the guidance.
Yes.
I have to say that this is something that's been a repeated issue for us. It's something that very often people hide behind because they're not able to, they're not willing to, for whatever reason, give those adjustments to those individuals to make things safer. And Phil was only asking for a phone call or a Zoom. It wasn't very difficult. It was perfectly available. It was something that they'd done before and that they'd chosen to deny at a point where it was clearly unsafe. So the pressure on those individuals to have to manage those risks. And again, Phil obviously made a particular choice, but someone else might have chosen a choice to increase their risk, and that could have led to obviously very severe consequences for those individuals. So they were being forced to make decisions that they should never have been forced to make. They shouldn't have been challenged in that way.
Yes. Well, I want to move on to the impact of rules and guidance. We started with a discussion of the definition of clinically vulnerable and clinically extremely vulnerable and how that changed over time. But in terms of the understanding and interpreting of subsequent government-issued COVID-19 rules and guidance, was there also, in the experience of your members, a confusion around the message or the messages that the government was giving and the level of those who were clinically vulnerable that would affect?
So, I think there was a huge amount of confusion about the level of the individual's health risk, because it wasn't always very clear, just as people have explained, that we were learning at that point. It was a new virus. We didn't know precisely how different groups were going to be affected. So there was that aspect, but it was also the extrinsic risks as well, so where their exposure might change and how they can manage those issues. I remember in the news at the time, I think both Matt Hancock and Grant Shapps said when shielding was ended for the first time, they said the vulnerable know how to look after themselves.
Was this the introduction of what we've heard described as personal responsibility?
It was edging towards that. So yes, exactly. It was this idea of, well, the vulnerable can cope with it now. They understand that they have to shield. We can just leave them to it. But it was still, it was summer of 2020. The virus was still around. We didn't have any vaccines. It was incredibly high risk. Potentially, if those people were exposed, the consequences for them were still very real. And so to put something that maybe even medical people didn't necessarily precisely know how at risk those individuals were, to expect them to understand and manage those risks at that point in time without giving them any tools to do so, without explaining to them, actually, there are these better masks. Yes, if you meet outdoors, then you're reducing your risk. If they had the tools and the skills, and everybody knew this, then we would have been reducing transmission overall.
Well, you tell us at paragraph 163 that many faced dilemmas, and you list them, such as whether to return to unsafe workplaces, how and when to mix with others, how to manage risks in enclosed indoor environments, which masks were the most protective, how to manage children returning to school, and how to access healthcare services safely in person. And what was the impact of those dilemmas that were being forced onto to people for decisions being made in those aspects of their lives?
So I think the impacts were, well, it kind of depended on what point of the split they came. So if people chose to completely withdraw, then there was issues around isolation and that's sort of one range of issues. If they chose to engage and face risks, then return to normal kind of became a priority at a certain point. And so their safety wasn't being prioritised, and they had to manage making those decisions and understanding the risks and consequences whilst facing stigma from society who was, were aware that where the government said stay at home, protect the NHS, save lives. Save lives was us. The finger was very clearly pointed in our direction. We were the reason that people had to stay at home. And so that started to kind of seed this idea that this group of people were almost responsible for the pandemic. They weren't responsible for it. They were facing the worst consequences of it. But the messaging at the time was hugely problematic. And personal responsibility was something that we never could have taken when it's an airborne virus. You can wash your hands, you can eat from clean plates, you can, make a sterile environment in a kind of a surgical environment or whatever. You can do things to reduce risks in all sorts of environments. But controlling the air is something that, as an individual, you can't do.
No. Thank you. The experiences of people that responded to your survey and that you have got to know throughout your work with clinically vulnerable families and that you've described to the inquiry today, are those experiences that have been shown to have been present across the United Kingdom, or have there, in your experience, been variations in impact between England and the devolved nations?
Okay, so I would say there have been some variations. However, I think overall, generally, it's pretty kind of homogenous experience that everybody understands and shares. And so within the group, there doesn't seem to be that many differences in terms of their experiences overall.
Was there a particular level of confusion amongst those living near perhaps regional borders or national borders in terms of the messaging that they were getting and a clear understanding of what could and couldn't be done?
I would say that, yes, there was. I think much of the UK messaging was across the UK. If you watched the news at the time, you could have watched, you were in England, but you could have watched the Welsh or the Scottish giving their kind of health updates, whatever they were doing at the time. I think for people in Northern Ireland in particular, because you've got two different countries overlapping, there were differences there that the people were crossing the border perhaps like more, well, maybe not more, sorry, but they were, I think many of the ideas between the two were kind of crossing. So there were influences. They talked about cocooning, not shielding.
Yes.
So there were different language, different ways of talking about similar things.
Right, thank you. I want to now turn to look at what you describe as the impact on specific clinically vulnerable and clinically extremely vulnerable groups. And we've touched upon this already. Those being key workers, those experiencing housing insecurity and homelessness, about which this module has heard evidence already, those living alone or in isolated areas, which you've touched upon, Ms. Wong, those in the immigration and asylum system, which we heard about with other witnesses, and finally, those in prison and other places of detention. Now, at paragraph 287, you tell us that a report by the Prison Reform Trust indicated that isolation measures appeared to be used in lieu of care. For example, clinically vulnerable prisoners were confined to cells for 23 hours a day without mental health support or adequate clinical oversight. And indeed, we're going to hear from some witnesses later this week who will tell the inquiry about what was going on in prisons and places of detention. But that is also your understanding of the position that took place throughout the pandemic.
Yes, and I think prisons, immigration, I mean, they've all got similar issues around people who are in certain circumstances, confined spaces, high population density, and increased risks. and potentially a population who may have higher clinical vulnerabilities. People in prison generally were of a male and of an older age and more likely to be ethnic minority groups. All of those things overlay with their clinical vulnerability, so they're more likely to be clinically vulnerable, more likely to be higher risk.
Yes.
Because of those risk factors, more likely to have certain conditions that put them in those risk groups. So it was a high risk population, or people who are homeless, their immune system drops because you're living a really exposed life. People who are homeless may live until sort of 43, 45 years old on average, so their immune system is reduced. They are at a greater risk, they're more exposed. So, and immigrants probably may face similar kind of risks. And so, where you've got a higher risk group with higher health risks, then it's a difficult thing to manage.
Thank you. And finally, on this topic, victims, survivors of domestic abuse. You tell us at paragraph 292 that for people living with domestic abuse, the COVID-19 pandemic posed additional serious risks, which we've looked at, and access to support services for those experiencing domestic abuse was significantly reduced as refuges and face-to-face support services struggled to meet social distancing guidelines and staff were furloughed. So that reduced the level of support.
Yeah.
Thank you. The intersection of clinical vulnerability and domestic abuse, you say, created a situation of extreme risk and for some near total isolation. Do you agree that the government failed during the pandemic to properly recognise the intersection between clinical and non-clinical vulnerability? And do you believe that left individuals with multiple vulnerabilities without appropriate support?
Yeah, so where people were clinically vulnerable but they faced those additional risks and challenges, then yes, they were a higher exposure risk, which then could result in sort of worse outcomes in that sense, but also, as I'm sure you're aware, domestic abuse abusers would use the virus particularly against those people who are very high risk, or use their medications, access to medicines, and the fact that they were shielding perhaps meant that they were already more isolated from other organisations who may have been able to help them, from friends, from family, and so they became incredibly high risk because they were unable to, even if they could find a space where they could speak openly about the risks and challenges that they were facing, they then would struggle to necessarily remove themselves from that environment, because if they were then moved into a place where there were lots of people living, then they increased their exposure risk as a result. So they were choosing between different harms.
Yes, understandable, that you describe it as such. Do you agree with others who've told the inquiry that unclear messaging around the right to leave and seek refuge placed clinically vulnerable individuals suffering from domestic abuse in a position where they were uncertain as to their rights and responsibilities?
Yes, because they also were given this guidance to tell them that they should be staying at home and restricting their lives. So it was completely in conflict with that. There was no consideration for how those things would interact.
Thank you. Finally, I want to turn to lessons learned, please, and to go through the list of multiple lessons learned, innovations and recommendations that you set out towards the end of your witness statement. First, early access to vaccines and treatments. Second, remote and flexible healthcare. Third, high quality data, which we've touched upon. Fourth, work adjustments and protections. Fifth, community support networks. Sixth, to feel seen and included, access to remote leisure, theatre and other venues. 7, regional examples of good practice. 8, to improve communication and messaging. 9, to develop practice guidance for isolation. 10, shielding letters and shielding infrastructure to be improved. 9, to protective measures indoors to be improved. And finally, as you have already mentioned, Ms. Wong, legal recognition of clinical vulnerability.
Yep.
Is there anything else that you would like to add to that list?
So just to kind of explain really our key issues, and just a reminder, obviously, that it continues to this day. In fact, today is the anniversary, the 4-year anniversary of living with COVID, where Boris Johnson told us that we will be learning to live with COVID.
Can I just implore you, please, to keep on impact?
Yes. So, but living, it leads to the impact, sorry. So living with COVID itself should have dealt with the ongoing issues. And the ongoing issues for us are safety, making environments safe enough for individuals who can't be expected to manage ventilation and things like that, and understanding about how their risks interact, how they can manage their own risks in difficult circumstances. Obviously, as you mentioned, the status and recognition that comes with that of clinical vulnerability,
yes,
as different to other issues, and particularly in pandemics. And the Joint Chiefs Intelligence Report came out recently, and it points to pandemics as one of our top 3 risks. So I think we can't ignore pandemics. We already knew we were overdue a flu pandemic, but for people who are clinically vulnerable, those intrinsic risks exist outside of pandemics as well. It's not a purely pandemic-related issue. Yes. They have health conditions that, if they're exposed to infections, then they will have worse outcomes, but they're not directly kind of considered in that way. And finally, the right to wear a mask. I think there's been some really harmful messaging around that, and people don't understand the benefits of wearing a mask. It would help people to be more resilient in the future if everybody understood that actually, if you've got a cold, maybe you could wear a mask. You could choose to protect other people and not expose your colleagues. Presenteeism has always been a problem in our culture, but it particularly disadvantages people who face those increased health risks. And so the right to wear a mask without being stigmatised, without having to go to your employer and justify, and many of us have had to do this, justify all of your health conditions as a reason to choose to wear a mask. We're already seeing tube stations are talking about cameras and the issues associated with people wearing a mask and going through those cameras and being identified, people's right to wear a mask during protest, things like that. That's where clinically vulnerable people need to be considered differently and yes, understood, because if they don't have the right to even choose to wear a mask, where we're left with personal responsibility is the only thing that the individuals have to manage their own clinical risks. If they can't even wear a mask, where does that leave them?
Thank you very much, Ms Wong. My lady, that concludes my questioning. There is permission for the Trades Union Congress to ask a question.
There is. Ms Peacock, I think you're asking a question.
Thank you, my lady. Good afternoon. I ask questions on behalf of the Trades Union Congress. My question is on personal risk assessments. The All Wales COVID-19 Workforce Risk Assessment tool was introduced nationally in Wales. The tool considered clinical vulnerabilities, or intrinsic risk, as you've described it in your evidence, and then workplace risks, or extrinsic risks, to generate a risk score. And that score formed the basis of a recommendation, such as a need for enhanced PPE, adjusted hours, or working from home. And the assessment involved a meeting between the employee and their employer to encourage shared decision-making. The TUC considers that in any future pandemic, efforts should be made to devise a national or ideally a 4-nations tool similar to that which was introduced in Wales and building on that work. Clearly, a great deal will depend on how the tool is devised and implemented, but in principle, do you consider that such a tool could have utility in supporting clinically vulnerable workers?
Yes, so we had people who were directly affected, obviously, by that tool. I think the tool still needs work. There was kind of a cliff edge at certain points, so I believe, I could be wrong, but I think if people were CEV, they were automatically receiving a score of a 7, which would mean that they were allowed to work from home. If they scored, I believe, from a 3 to a 6, they would have had significant health conditions, but they would have had to work potentially in a high-risk environment still. Should not be the highest risk environments, but it didn't necessarily address the direct risks that they were facing, and they were not being necessarily allowed to wear high-grade masks. Sometimes people were told that it was problematic if they were to wear a mask, particularly even in healthcare. They were told that they weren't allowed to wear a mask because other people would question why they were wearing a mask in this area, and other people who weren't as high risk were not being given those same masks. So there were difficulties that were kind of created. There were issues around it. I think that any consultation around it should involve clinically vulnerable groups, so that then they can feed into this and recognise the issues that were created. But in general, broadly, we do recognise that this was a good idea. But I think there's still more work to develop it.
So, if I may, standardised risk assessment tool would be helpful, but
Yes.
it needs work so far as you consider it. And consultation would be helpful with people who fall into the category of clinically vulnerable. Do you have any other thoughts on how it could be improved, the criteria, so there aren't these cliff edges?
So, I mean, I think we need to look at and understand the individual risks and the circumstances. And certainly, I think, the cliff edges could have been avoided if we looked, it wasn't so kind of such a, where you reached a 7 and then there was a massive drop-off. If we would be more open to giving people remote work, for example, remote work is something that many people can do, not everybody, but there would have been opportunities to support people better in that way, to take them out of that risk environment. And I think there probably does always have to be a degree of a cliff edge, but if we're making the environment safer, if we're improving the ventilation in those buildings so that everybody is at lower risk, everyone benefits. I think one of the things that we try to kind of get across is the fact that when it's safe enough for the most vulnerable, it's safe enough for everyone. And so we would like environments to be generally improved, and it will make everyone healthier. Catching viruses can harm your health in the long term, and the long-term impacts and benefits of having cleaner air, something that we're starting to see in London as we've kind of introduced the clean air zone. There's evidence of that already. And so if there's something that we really should be learning from the pandemic, it is actually that there is something that we can do about indoor environments. It's quite simple. We can buy these air filters that are behind me. We can put them in. They might only cost £100. But it can make reduce the risk not only of airborne pathogens, but also other airborne sort of chemicals and things like that. So any other kind of exposure risk can be reduced, mould, things like that. And then we can hopefully make it safer for everyone is what we would really like to see. And then it becomes less of a cliff edge because the environments are safer. People understand how to wear a better mask.
Thank you. I'm sure my client would support improving WorkSafers generally. Thank you, my lady.
Thank you, Ms. Peacock. That completes the questions we have for you, Ms. Wong. I always remember, I think it was probably a different module, but I think it was AM3, our very first hearing when Mr. Wagner pointed out about the quality of the air in that room. And I think I was holding my breath before he told me we passed. But I've certainly learned a great deal from you and your colleagues during the course of the inquiry. So thank you very much indeed for your help. And I do understand the points you're trying to make. Obviously, if you feel there are other points that you wish to emphasise, then Mr. Wagner can always put them to me in any closing submissions.
Thank you
Thank you very much for your help.
Thank you so much. And may I thank you all and all of your staff as well for their hard work to make this environment a really inclusive environment. I think the COVID inquiry is probably one of the safest rooms in the country that you can be in. So I think thank you for all of your work for that and for your team to make it safe and inclusive and friendly and the really lovely team that you have.
Thank you, Ms Wong. My lady, that concludes this morning's business. Could I invite you, my lady, to return at 1:25.
You may.
Thank you very much.
Bye.